Currently, she's serving as the MRI clinical lead consultant radiologist at Northern Imaging Victoria in Australia. Dr. Jyoti has previously held roles in Singapore General Hospital, including consultant radiologist and director of education in diagnostic radiology. Dr. Belanga is a fellow of the Royal Australian and New Zealand College of Radiologists and also holds prestigious certifications, including the FRCR from UK and EDIR from European Board of Radiology. Her career spans leading institutions in Australia, Singapore, and India with strong focus on MRI, radiology education, and clinical leadership. Please join me in giving a warm welcome to Dr. Jyoti Velanga to speak to us today. I think we are really lucky to have you, and we are all eager to glean a lot from you, Dr. Jyoti.
Thank you so much for your kind introduction, Dr. Ritu. It's absolutely my honor to be here. And it's, as I said, it's amazing to see the collaboration between radiology and clinical teams, the gynecology team. I don't think that you see that often anywhere. I think this is absolutely special. And I'm really privileged to be sharing this space with you today.
Thank you.
Yeah, absolute honor.
Yeah, Dr. Jyoti, let me quickly introduce our two moderators for the session. This is Dr. Ritu Nambia. I don't have to introduce her at all in this part of the world. She's an accomplished consultant in obstetrics and gynecology with an impressive 31 years of experience in women's health, reproductive medicine, and minimally invasive surgery. Dr. Nambia earned her education from India and UK. Dr. Ritu began her medical journey in India and Saudi Arabia. Since 2009, she's been serving in UAE across reputed institutions. She has been repetitively recognized for excellence in patient care, receiving numerous awards such as Doctor of the Year, SEHA Best Physician Award, and a Silver Award for work on gestational diabetes. Beyond clinical care, Dr. Ritu is a committed academician, having presented papers, led workshops, continuously engaged in skill development and education in women's health. Her dedication, leadership, and commitment to improving reproductive healthcare make her an inspiring figure in this field. Please join me in welcoming Dr. Ritu Nambia. And our second moderator for the day, Dr. Monica Singh, her video cannot be switched on due to some technical glitches. She is a consultant obstetric and gynecologist with over 2 decades of experience, earning her education in India and US, and she specializes in minimal access gynecology. She also served as assistant professor for 12 years in Central India and holds fellowship in advanced laparoscopy and hysteroscopy. She's also the first in Abu Dhabi trained in aesthetic gynecology by Dr. Reed Allinson, University in California, with a diploma in pelvic reconstructive and vulvovaginal surgery. Welcome each one of you to this amazing session. Over to you, Dr. Jyoti, as we begin our CME. Thank you very much.
Thank you so much. Yeah, I'm just going to quickly share my screen. Looks like it takes a little bit of a lag to share it. There you go. Okay. May I just quickly check if it's projecting correctly?
Yeah, it's perfect.
Yeah. Awesome. Thank you. Thanks again for having me with you today, and it's true. I think it's my absolute privilege to be with all of you today with such amazing, accomplished people. And today's my topic is acute female pelvis on CT, and we're going to look at, or rather, power through a few cases for the next 30 or 40 minutes or so. I'm Jyoti, and I'm based in Melbourne. There you go. So Melbourne is a bit unique because right now we are entering winters. And when I moved to Melbourne 2.5 years ago, people told me that there are at least 4 seasons a day in Melbourne, and which I did not believe it. But I'm now a believer, and I experience that every day. So it can just change, the weather can change within just minutes. And right now we are in winter. And the unique thing about Melbourne winters are sometimes it is colder inside the house than outside. And today is such a day, so I've got my heater cranked up and I'm wearing jumpers in the house. So I don't have any disclosures for the talk. And the main objectives for the talk are to first recognize the key CT imaging features of acute female pelvic emergencies, and then to appreciate the role of CT in these cases as problem-solving tool. So why are we talking about CT? We all know that gynecological issues and abnormalities are usually evaluated by ultrasound, which is the first line of investigation in most cases. So a lot of times in ED setup, when the presenting complaints are a little bit non-specific and the physical examination is not really pointing to a gynecological cause, or the gynecological cause has not been thought through, so these patients somehow trickle down to emergency CT. They bypass gynecological consult and they end up in our CT pile. So this is one subset of population that we're going to look at. And sometimes we know that it's a gynecological issue, but we may still need to scan CT on emergency setting. And these cases happen because maybe the ultrasound findings were equivocal, or maybe it's just that we needed a lot more information and the ultrasound probes probably couldn't really reach all the necessary areas that we want to look at. So these are two different areas where these set of population get CT done and then end up in our CT piles. So what we're going to look at today is when we think of acute female pelvis, so we can put them into different categories. One is adnexal and ovarian abnormalities, uterus and related abnormalities, and a mixed bag of cases such as, gyn-oncology being a big part of it, and even pelvic endometriosis. But oftentimes the extra gynecological causes are more common than the gynecological causes in a day-to-day ED setup. And of course, we're not going to look at it, but for completion's sake, that's the first thing we're looking to rule out. So moving to ovarian cases, the first case or set of cases I'm going to show are cases of ovarian cyst rupture. So when we talk about ovarian cyst rupture, we're looking at two types of cysts. It could be a simple cyst or it could be a complex cyst. So simple cyst could be a rupture of corpus luteal cyst or a follicular cyst. And complex cyst, it could be an endometriotic cyst or tumor, most commonly a dermoid. So hemorrhagic ovarian cysts, usually they're physiological, self-limiting, but if there's a lot of bleeding and hemoperitoneum, and that can be life-threatening if there are symptoms because of blood loss. So oftentimes it involves corpus luteum cyst more than follicular cyst. That's because there's increased vascularity in the ovary, in the luteal phase, especially for the corpus luteal cyst, that predisposes to cyst rupture. And these ruptures or cyst accidents are usually associated with intercourse, exercise, trauma, and pregnancy. And it is thought that the left side of the ovary has some protective anatomical protection from the adjacent sigmoid colon. So it's more commonly seen on the right side. But having said that, I've got a few case examples that are actually on the left side. So when we look at hemorrhagic cyst, I think on CT, usually there's not a question that there's a lot of hemoperitoneum and probably due to an ovarian cause. The main question then is whether the cyst that we are seeing, is it a simple cyst or a complex cyst? So if we see a cyst with a fluid level, it's more reassuring that we're looking at a benign pathology that has bled, which is more likely a corpus luteal cyst. But if because of the hemorrhage or the age of the hemorrhage, if the signal change or the attenuation is a bit mixed, then we may have to do a further ultrasound or an MR later on, and depending if the patient is stable, to assess if there's any underlying lesion. So one thing about corpus luteum is it's got a very unique appearance, and it's same across different modalities, be it ultrasound, be it CT, be it MRI. It's got a very similar appearance. It's got a brisk peripheral enhancement and sometimes crenulated borders. So at least in our setting, when we do emergency CT, it's usually a portal venous space. We don't usually do a delayed, but in problem cases where we need to establish, sorry, there's a bit of there is a bit of feedback coming through. If you can.
Dr. Jyoti, just unmute yourself. Sorry.
Someone has muted my mic.
No.
Sorry about that. Okay, going back. All right. Okay. So yeah, if we want to establish that there's active bleeding or contrast pooling, a delayed may be useful, but oftentimes that usually doesn't happen. The most important differential diagnosis in this setting is, of course, an ectopic or ruptured ectopic pregnancy, and this needs to be correlated with the beta HCG levels. So, but the set of population that we are going to talk about in this talk are the non-beta HCG, non-ectopic, or non-pregnant women. So in cyst ruptures, the treatment is usually conservative and supportive. So we got a first case. This is a 22-year-old woman with 2-day history of left lower quadrant pain. So if you can look at the images, so I've got a red arrow. If you look at the red arrow, so this is a typical appearance of a corpus luteum cyst. It's got a very beautiful peripheral rim enhancement. And you can see the green arrow points to slightly increased attenuation of the ascites, which is hemoperitoneum. So this is a classic corpus luteal rupture on CT. And this patient was conservatively followed up, managed, and the follow-up demonstrated complete resolution of all these findings. And the second case is a slightly bit more dramatic in the sense there's a lot more hemoperitoneum. There's a lot of dense fluid in the pelvis. And the left ovary seems slightly enlarged. It's a focal rim enhancement. We don't know at this point in time whether it's a corpus luteum that we're dealing with or if there's any underlying lesion. So this patient underwent an ultrasound and it shows a classic peripheral vascularity that is expected to be seen in a corpus luteum cyst. Again, this patient was also managed conservatively. And we have yet another cyst. This was a large cyst in the right ovary, which has just blood internally as well as into the peritoneum. So this is just a case of normal ovarian cyst that has ruptured. So moving on to abnormal cysts or a complex cyst. So this is a case of endometriotic cyst rupture. So this was a 27-year-old woman who had sudden onset of pain. But for her, she has had a previous history of rupture and known endometriotic cyst as well previously. So a CT was first performed, which shows a large cystic lesion in the mid pelvis and a bit of hemoperitoneum as well. But I think there was a question of maybe there's a bit of solid component, cannot really assess properly. Ultrasound was equivocal. So this patient went on to do his MR. So on the right hand side, we've got MR T1 on top and then T2s at the bottom. So on top on T1, you can see that it's all hyperintense. It's all bright on T1, which means it's blood in this particular case. T2, it's a little bit darker than T1, which is what is called shading on ultrasound. MR. And also we can see there's a bit of fluid level. So this is in keeping with an endometriotic cyst. So it was confirmed on MR and later on confirmed in surgery as well. So this patient actually had to go in for surgical management. And another set of cyst accidents occur when there's an underlying lesion, such as, for example, in this case, there's a right-sided dermoid cyst. So if you can look at the red arrow here at the bottom, there's a bit of irregularity of the margins and the rim, and on the top axial right-hand side, there's a bit of a paucity of wall along the medial aspect, so which raises suspicion for rupture. But if we go further up to the liver, we can see a few deposits which are fat density, which confirms rupture of the dermoid cyst. So again, this patient also had to undergo surgery. So there's another case which I don't have it here. Sometimes ovarian cystic tumors can also rupture. In such cases, instead of fat deposits, we may find low density deposits, which is again known as pseudomyxoma peritonei. So that can happen, but quite rare. So moving on to adnexal torsion. So this is often a leading diagnostic consideration in the setting of acute pelvic pain. And especially when there's a bit of intermittent torsion, detorsion, and on and off symptoms, sometimes the index of suspicion may be quite low, and this may eventually lead to delayed diagnosis and delay in ovarian salvage. So this is most commonly associated with benign ovarian masses, which are more than 5 centimeter, or sometimes usually large cysts and cystic neoplasms. It's slightly less common in malignant ovarian masses or even endometriotic cysts because these situations, they usually have adhesions and they kind of render the ovaries less mobile. So they don't really tort as easily as a benign mass or a large cyst. And most of these torsions are associated with dermoid cysts. And torsion of normal ovary can happen, but rare. So CT features, when we look at CT features, we divide the features into direct and indirect. So direct features, when we actually see that the pedicle is twisted or anything related to that, is designated as a direct sign. But if there's interruption of blood flow, inflow, outflow, or lymphatic outflow, so these give rise to indirect findings. So what is this pedicle? So this pedicle actually contains a thickened fallopian tube, and it's contiguous with the uterus. It appears wall-like appearance, or it appears kind of a round, structure just next to the uterus, or the uterus, and sometimes it can just look like a mass next to it. So these are the direct and indirect signs. So if you follow the arrow, so there's a bit of whirling like sign on the left, right adnexal. So this is the classic twisted pedicle. It's pathognomonic for adnexal torsion. So when the pedicle whirls or twists, it actually pulls the uterus to the same side because the adnexal ligament becomes shortened. So that's another sign or direct sign of ovarian torsion. So we're looking for twisted pedicle, and we're also seeing that the uterus is pulled towards the same side of the twist. And indirect signs, the most common indirect sign we come across is asymmetrically enlarged ovary, which is more than 4 centimeter. And although this is most common, this is also non-specific. And if the enlarged ovary has a lot of afollicular stroma in the center with a bit of peripherally displaced follicles, this is more specific than just an enlarged ovary. And we can also see other features like there's a lot of, there can be hemorrhage of the entire ovary, or there can be a lot of inflammatory standing and even hemoperitoneum in some cases. So this is an example of ovarian torsion in a young woman with lower abdominal pain. What we see here is the uterus, and the ovary sitting right on top of the uterus, which is again abnormal location. And if you see on the left side to the ovary, this rounded structure, this is actually the twisted pedicle, which is pathognomonic for ovarian torsion. And for this particular case, there was another cyst-like lesion in the POD. So this patient actually underwent MR to further assess the extra cyst that we see on the in the POD. So the bottom images are MRI images. And what we see is there was an additional endometriotic cyst in the pouch of Douglas. But what it confirms is a necrotic ovary that's pretty dark on T2 with some cystic areas. And this is the twisted pedicle, which is pointed out with the red arrow. And if we look at the right-hand images, this is actually a post-contrast image. There's absolutely no enhancement of the ovary. It's completely necrotic. And the inset shows you pre-contrast just for comparison. And this is a case of torsion of ovarian dermoid, and we see this is a classic dermoid cyst. But if you look at the position, it's abnormally located. It's slightly anterior and slightly higher up in the pelvis. And what we see is a normal left ovary, but we can't see a normal right ovary at all. And if you look at the coronal images here, pointed out by the green arrows, so we see a nice twisty, rounded thing. So this is the twisted pedicle in this case. Again, it's pathognomonic for ovarian torsion. The other supportive features are again abnormal location of the ovary and a lot of hemoperitoneum as well. And this was histology confirmed torsion with a dermoid cyst. So this is yet another young pediatric patient who presented with 3-day history of right iliac fossa pain with fever and some one episode of vomiting. Again, if I can ask you to look at the green arrow, again, we see a nice twisted pedicle, which is quite pathognomonic for ovarian torsion. And in this particular case, the whole ovary is heterogeneous and it's quite bulky and enlarged. So this patient underwent right oophorectomy and salpingectomy. And on histology, this ovary had a lesion, which was Sertoli Leydig cell tumor. So we've seen a few torted ovaries, but then there's another entity of torsion of hydrosalpinx as well. So in this particular case, what we're seeing is this tubular structure, which is very cystic, maybe with slight increased density. So this is anterior and slightly higher. It's retort-shaped, typical for a distended fallopian tube, and its abnormal location, history of pain indicates torsion. We could see the right ovary separately. Of course, we can see a nice corpus luteum as well, but the left ovary on CT was not seen clearly, and there were supporting signs such as hemoperitoneum as well. So this patient underwent a left partial salpingectomy. On surgery, the ovary was actually quite fine. So this is a case of torted hydrosalpinx. So when we're looking at isolated fallopian tube torsion, it's usually rare. So a torsion can involve anything. It can involve the ovary, it can involve the fallopian tube, or both. But most commonly is a combination of both the ovary as well as the tube. And when we're looking at fallopian tube torsion, we usually see associated tubal abnormalities such as hydrosalpinx or previous tubal ligation, or sometimes even tubal or paratubal masses. So, but the clinical symptoms are very similar to that of the ovarian torsion. So what we see in fallopian tube torsion is just an adnexal cyst, but what's very important is to see the ovary separately. In our case, on CT, we just couldn't see it, so we actually gave it as both ovarian as well as we just gave it adnexal torsion involving both ovary and tube, but intraoperatively, it was just the fallopian tube. So why is this important to identify whether the ovary is separate? Because if it's just a twisting of the fallopian tube, oftentimes the blood supply of the ovary is spared and ovary usually doesn't get affected. So again, it kind of increases the window of surgery. So that's why this is important to see that the ovary is separately seen and looks normal. So now switching gears to pelvic inflammatory diseases. So these are infections of upper female genital tract involving the endometrium, fallopian tube, and ovaries. So usually affects young women of reproductive ages. So this is a bit of a clinical continuum. It has a gradual progression from one condition to the next. There's no distinct separation between different stages of the progression. So because of that, on imaging, we just see some basic general imaging features or sometimes a group of imaging features. So this is why the clinical correlation becomes very important here to know whether the patient has fever or is inflammatory markers and such. So general imaging features can be anything. It's a spectrum from just thickening of uterosacral ligaments all the way to peritonitis. And early signs may be cervicitis, endometriosis, salpingitis, and tubo-ovarian complexes, as well as oophorytis. And the late stages on CT, we can see pyosalpinx, hydrosalpinx, tubo-ovarian abscesses, and even pyometra. So what's important here is, in addition to diagnosing PID, it's important to understand the complications because these are, they usually result in tubal damage. So that's quite an important thing to remember when looking at PID. And sometimes the abscesses can rupture, causing peritonitis. There can be peritoneal adhesions and a condition that we'll see in a bit. If it's Hugh-Curtis syndrome, sometimes even ovarian vein thrombophlebitis, and rarely uterine rupture as well. So what do we see on CT? So we see a lot of low density cystic structures, but with thick periphery and thick walls inside. So there can be other associated features such as there can be a lot of ascites. Sometimes the uterine wall can be fuzzy. You can't really differentiate between the uterine wall and the adjacent fat stranding. It can generally be quite edematous as well. And there can be complex large cystic lesions in either one side or both sides in the adnexa. So, and there can be association of or inflammation of the adjacent structures. For example, in the pelvis, there can be reactive appendicitis, there can be reactive colitis, or sometimes even extending all the way to the greater omentum. So this is a 34-year-old woman with a known history of PID. Now she presented with one-day history of left iliac fossa pain and fever. So here we already know the history and we know what we're expecting. So when we look at the CT, we see large cystic masses both sides of the adnexa and bilateral adnexa. So we have a nice peripheral enhancement. We have some internal septations. So this is in keeping with PID, tubo-ovarian abscesses. So there's some free fluid as well that's just seen in the pelvis. So the ovaries, the uterus is slightly to the side, it's pointed by the asterisk. So this particular case had to undergo ovarian abscess removal and bilateral salpingostomy and reconstruction of the ovaries. And histopathology confirmed abscesses, there was no underlying mass. So this is yet another case with a woman presenting with upper abdominal pain, with fever and raised inflammatory markers. So bedside ultrasound showed some free fluid in the right upper quadrant with beta HCG negative. And so this again bypassed gynecology consult. That's why this patient ended up in our CT pile. So the question was whether there was a perforated viscus or if there is a pelvic mass or infection. So as you can see, if I can ask you to look at the green arrow. So this is a normal left ovary. It's small. It's just partly imaged on this particular slice, but the majority of the lesions are on the right side, and these are cystic, slightly hyperdense than fluid, nice thick walls, and maybe some thickened septations. So again, possibility of TAO was raised, but this patient was conservatively managed with, she did very well with antibiotics, and then she was just discharged with 14 days course of antibiotics. So this is another case. This is a 34-year-old woman who presented with recurrent right upper abdominal pain. She had normal biochemical and hematological parameters. Urine pregnancy test was negative, and at the time of scan, the blood culture was still pending. So there was already, they're thinking of something, but they just didn't tell us what it was. So if you look at the pelvis, what we see here is a nice thickened enhancing endometrium. So this is endometritis. And if you look at the uterine wall, so you can see the uterine wall, there's a little bit of edema, but the distinction between the wall and the edema, it's actually quite hard. If I take a pencil and draw it, I can't seem to draw the uterine wall correctly. It's very fuzzy. And if you look at the liver, and there's quite a bit of portal edema. It's pointed with the black arrows. It's just this dark line next to the bright portal veins. So the constellation of these findings indicate PID with a Fitzhugh-Curtis syndrome. And for this patient, the PCR came back later on. It was positive for chlamydia trachomatis. So usually what happens in this syndrome is there's inflammation of the liver capsule, or basically perihepatitis, when there is a background PID. So there were many mechanisms that talk about how this happens or why this happens. But I think the most commonly accepted one is the transperitoneal ascending infection from the pelvis along the right paracolic gutter. It's very akin to how the ascitic fluid flows. So very similarly, you can actually find inflammatory changes in the right paracolic gutter as well. And sometimes the liver is just not thickened with periportal edema and capsular thickening. Sometimes we can see a bit of abscesses in the perihepatic region as well. And there can be reactive mural thickening of the gallbladder as well. So in exploratory laparotomy, what they say is classic violent string-like adhesions between the abdominal wall and the liver capsule. So Neisseria gonorrhea or chlamydia trachomatis, these are isolated either in the cervical smear or in the peritoneal fluid. So this really supports diagnosis. But when we see these findings isolated in the upper abdomen, of course, there are a lot more other differential diagnoses. So this needs to be thought of when there is a background or coexisting PID. So the treatment is usually antibiotics and supportive therapy, but occasionally surgery may be required to relieve symptoms. Okay, so just a quick breather that we all are doing okay. Okay. So now switching gears, we're just moving, we've just seen a bunch of ovarian or adnexal abnormalities. Now we're moving to uterine emergencies. So this is actually a 70-year-old. So again, a different age group from what we've seen before. This is a 70-year-old woman who presented with lower abdominal pain and increasing abdominal girth. So this is actually a non-contrast CT. So what we see here is a really large uterus, and there are multiple fibroids inside. So some of the fibroids are calcified, but we also see a lot of high attenuation material in the uterus, which actually implies blood in this case because there was no contrast, intravenous contrast given. But if you look at the green arrow, there's a little bit of twisting and twirling, very similar to the ovarian torsion, that we've seen. So this is a case of ovarian torsion, uterine torsion. So the site of torsion is usually at the cervical isthmus, is at the junction of the lower uterine segment and the cervix. So this is the classic site of uterine torsion. So this patient underwent a surgery. So there was hemorrhagic myometrium, which correlates very well with what we're seeing on CT, like a lot of hyperdense material in a non-intravenous contrast CT. There were multiple fibroids, areas of infarction, and both ovaries were also infarcted. And we do have another case. This is a slightly younger woman, 52-year-old. Again, pain with lower abdominal pain for 2 days, not improving. Again, what we see is a large uterus here. And here the whirling is a bit more larger than the previous one. So if you see this, the whole thing here where my mouse is pointing to is the twirling or twisting at the level of the cervical isthmus. So in this particular case, the ovaries were viable for her. So when we look at ovarian torsion, what we see again, very similar to ovarian torsion, we do see whirling appearance at the level of the cervix. And oftentimes the uterus is quite large. It can have underlying abnormalities like multiple fibroids. And there can also be ancillary findings. For example, there can be fluid distended endometrial cavity, there can be hydrosalpinx or other uterine abnormalities. So there's a bit of thing about gas I forgot to mention. So when we're looking at tubo-ovarian abscesses, we know that in the body abscesses tend to have some gas, but presence of gas is actually not very common in tubo-ovarian abscesses. Again, coming back to uterine torsion, we can see gas in the uterine wall because of necrosis of the wall. So uterine torsion is actually quite rare. It can happen or it's been reported in pregnancy or patients who have underlying congenital uterine anomalies, or even patients who have basically a large uterus, which can have a lot of fibroids, gravid uterus, or other congenital uterine anomalies. So this is a 36-year-old woman. She previously has had history of laparoscopic myomectomy. So now this is the first pregnancy with twins. As you can see, there are two skulls in her uterus. So now she presented with sudden onset generalized abdominal pain, an acute hemoglobin drop, and ascites, which was seen on the bedside ultrasound. So what we see here is, first of all, of course, a gravid uterus, but there's a rent at the top of the uterus, and there's a rim of hemoperitoneum surrounding where the uterine rent is. And what we see is a gaping hole between this is the placenta, which is very bright on either side of the red arrow. And the red arrow points to the gaping hole or gap in the uterine cavity. And there's also quite a bit of hemoperitoneum elsewhere, along with a bit of pleural effusion and a bit of hemoperitoneum adjacent to the liver as well. So this patient, of course, underwent an emergency surgery. There was a large 4-centimeter defect at the posterior uterine wall. And there was also partial extrusion of the placenta and a very large amount of hemoperitoneum. So uterine rupture occurs in 3 different scenarios. One, if there is a presence of uterine scar, for example, post previous C-section or previous myomectomy, or sometime trauma to an unscarred uterus, or just a spontaneous rupture of an unscarred uterus. This is rare, but it's catastrophic and life-threatening complication that can occur in pregnancy. So again, this can be a full thickness tear, like what we've seen in our case, or sometimes it can be just a partial thickness tear, and there can still be serosa on top or kind of tamponading the hole or the rupture. So usually, of course, ultrasound is the first line of investigation. It's safe for pregnancy, and MRI can give a lot more information. But since this is really emergency and life-threatening, and many centers may not have urgent MR machine or expertise, so CT would be the right choice in this kind of setting. Okay, so now looking at a few post-procedure complications for the uterus. So this particular patient had a difficult DNC, very rigid or partly calcified RPOC removal. So during the removal, she had heavy bleeding, and the gynecologist suspected there could be some sort of a complication during the procedure because it was already hard to begin with, and the CT scan was arranged to assess if there's any complication. And as you can see, there's quite a bit of hemoperitoneum, moderate sized hemoperitoneum in the pelvis. And if you can see at the left parietal aspect of the uterus, the whole area of the wall is hypo-enhancing. We see beautifully enhancing uterine wall, but there's this area that doesn't enhance. So a possibility of a wall rupture was raised, and this patient was again taken back to surgery. There was 1 centimeter defect in the lateral wall of the uterus, and this was just sealed off by a flow seal. And also you can see incidental right dermoid cyst, just incidental in this case. So another case of post-LSCS hemorrhage. So this patient had LSCS and the hemoglobin was dropping and was just not holding even after transfusion. So I included this case to actually demonstrate not the complication, but something else. But so what we see here is this is the uterus, and in just anterior to the uterus, just opposite to the the LSCS site, we see a bulky hematoma that's just sitting anterior to the uterus. But what I want you to see is this bubbly lucencies between the uterus and the hematoma. So this is actually Surgicel is just because the gynecologist specifically mentioned in the clinical history that we did use Surgicel, and it's about 5 centimeter, and this was exactly 5 centimeter. So the idea of this case is for us to remember that there are different types of hemostatic agents that are used, and it's important to know what they look like, and when in doubt, always to check with the surgical team to see if they've used any of that. And for this patient was treated conservatively, and she did quite well and discharged eventually. There's another case of post-LSCS hemorrhage. This was a 35-year-old woman. Again, hemodynamically not stable, dropping hemoglobin. So here, this is very different from the previous case we've seen. So this entire thing where my mouse is pointing out to is the uterus. So we can see that it's enhancing quite well on the left side, but there seems to be a huge rent here on the left-hand side. So here, the rupture was actually quite far away from the surgical site. And what we also see are these really bright lines. So this is actually active bleeding, and there's a sizable hemoperitoneum as well. Again, this patient was taken to surgery. Rupture was confirmed, which was remote from the surgical site. And there was, by then, there was no active bleeding. There was a lot of hemoperitoneum that was drained. And this rupture site was closed surgically. So now moving to endometriosis. So usually endometriosis, we go for ultrasound or MRI to assess. So there's a bit of a echo coming through. Okay. So for pelvic endometriosis, the first line of investigation is usually ultrasound, and we further assess with MR. But sometimes, rarely, like the next 2 cases, we'll see that sometimes the diagnosis may be unknown, and we may pick it up because of a complication, or maybe the patient already is a known endometriosis case, but then presenting with the complication. So that's so the role of CT here is to look at extragynecological complications. So the first case in pelvic endometriosis is what we have is this thickening of USL on both sides. And if we see on the right-hand side, there's abrupt cutoff of the right uterus, and then there's also concurrent hydrouteronephrosis on the right side. So this is a pelvic endometriosis involving the or extending to the distal right ureter as well, resulting in obstructive hydronephrosis. So this patient underwent stenting with relief of the hydronephrosis. And this is another case, not known endometriosis. This patient presented with question mark intestinal obstruction. As you can see, it is confirmed intestinal obstruction. But what's present here is this lobulated enhancing lesion, and that was actually causing the intestinal obstruction. Of course, there are lots of differential diagnosis when you see something like this, but this particular patient, someone astutely picked up possibility of endometriosis on CT, so that which needed further characterization, and patient underwent an MR, where you can see there's quite a bit of USL thickening, there's a bit of endometriotic deposit, and retroureteric nodule that's also involving the bowel, what we see something like a mushroom cap. So this is a case of small bowel obstruction causing, endometriosis causing small bowel obstruction. So occasionally we do pick up incidental findings like this, and that's where we can be a bit of a hero and say, okay, there's actually a lot more going on than just bowel obstruction. Okay, so we're almost towards the end of the presentation. So I've got just a couple of cases. So this lady is a 50-year-old woman. She had an echo done and they found a clot at the IVC and RA junction and then asked for a CT for further investigation. So on the CT, what we see is some filling defect on the IVC marked with the red arrow. And there's also filling defect extending to the internal iliac vein, and which led to some cystic areas just next to the uterus. And if you look at the uterus, there are multiple fibroids in the uterus. So a diagnosis or a differential diagnosis of either a leiomyosarcoma or intravascular extension of leiomyomatosis was raised. But this could not be definitely characterized on CT, and the patient underwent a subsequent MRI. So MRI confirmed what we've seen on CT, this distension of the internal iliac vein, this multiple cystic structures just next to the uterus containing some weird stuff inside, which seems to be contiguous with the vessels. Again, the same differential was also given on MR because a confirmed diagnosis could not be established. And this was surgically dealt with, and this was proven to be a benign leiomyoma with intravascular extension. So that's one case. And the other case, this is actually a very interesting case. This patient presented with left leg swelling, and the DVT scan was negative. So the next best thing to do was to do a CT to look for a cause. So on CT, as you can see, there's a lymph nodal deposit in the left iliac station, and we can see the right left ovary separately here, where my mouse is pointing to. And this is actually reported by one of my friends, and she astutely picked up a bit of a thickening or varied appearance or thickening of the endometrium, but wasn't entirely sure. For some reason, patient bypassed ultrasound and went ahead to do an MR. So MRI confirms presence of endometrial lesion with a lymph nodal deposit in the left iliac, external iliac station, and we can see the ovaries completely normal and seen separately. So this was a case of endometrial cancer with the lymph nodal deposit. So, these are rare cases, but sometimes we can pick up gynecological abnormalities when it was not even thought of. Yeah, so these are the cases I've got to share today. And just to summarize, of course, we've seen a plethora of cases, but most common conditions that come into our CT pile are just these. Of course, the most common one is cyst accidents. We know how to investigate, and the most important thing here is to rule out ruptured ectopic. So that is the most essential differentiation from a cyst accident. The other subset of cases that we're going to see are tubo-ovarian abscesses. Here, most of the times, the clinicians may already know the diagnosis. Our role is to actually add in if there's any complication, what's the extent, and some direction to what sort of treatment may be required. And torsion, sometimes because of torsion, detorsion, symptoms are not really indicating to torsion, and such cases can also come into a CT pile, and here time is key. So it's important to know not just the direct findings of the torsion, but also indirect findings to help us think that, okay, this could be torsion. And we're actually increasingly seeing endometriosis cases or the complications of that coming in through the ED. So that's something to keep in mind as well. And usually for post-op complications, we already know the history. So we already have that thought process in a place that, okay, we're going to look for rupture or active bleeding. So if there's one takeaway from the entire presentation, is just this slide. Yeah, so these are my references, and I'm just going to quickly take another minute. And we do have annual conference in Melbourne coming up in October. So I welcome all of you, if you're looking to join us or just to explore Melbourne or even Australia, please do come join us. This is in October from 23rd to 25th this year. And that's all for me.
Let me open the house for any questions. Any questions, anyone? Any questions or any comments?
We just send our patients off to radiology. We are getting to see from the other side. I guess it's an eye-opener for me. So much more information we need to feed into the system so that we get the best out of you. Look at the things you've picked up even without any suspicion from the OB. It's amazing, Dr. Jyoti.
Thank you so
And
much.
the radiologists will have a lot of doubts. I'm still amazed at the work that you guys do. It's really top-notch.
Absolutely, an excellent collection of cases. And as Dr. Jyoti says, CT is not the modality, and pick up, acute female emergencies on CT. You have to be very good at it. And this is also a specific request to all the GPs and ERs, women, reproductive age, children. Whenever you have lower abdominal pain, as radiologists, we always suspect, all these ovarian causes, uterine causes. So if you give us a little bit more clinical information, the pickup becomes very high. So yeah.
This was an excellent presentation, Dr. Jyoti, because it is so crucial that there is the decision between the imaging and the intervention really, guides our management. If there is no diagnosis, there is no intervention. It goes like that. So it was a very interesting and very, very useful presentation for us. In my entire career, I haven't seen a uterine torsion. Dr. Ritu, have you seen? And and it's interesting that you have put that up and you have put the images, because I haven't seen in my career yet a uterine torsion. And in your this presentation, this case that you shared, it is all in your center, or have you it is from other facility that you have picked up those cases?
Yeah, thank you, Dr. Monica, for your kind comments. Really appreciate it. So most of my cases are actually from Singapore General Hospital, and some of the cases are from Melbourne, where I'm working here. But both the uterine torsions are from Singapore General Hospital. So
Yeah, haven't seen, yeah, true.
Did they have prolapse uterus, or like really it is for us it is very interesting that madam, have you ever seen a uterine torsion ever?
Never. In fact, I was just, and I hope I wouldn't see one either.
Yeah, we
But
can
we-
only hope.
Actually, this part of the world where we have so many, pregnancies, we should, in fact, as radiologists, we should always, have an eye for torsion next time, where the uterus is deviated to either sides. I mean, next time, yeah, when I look for a acute abdomen, I'll definitely, look at the deviation of uterus or at the, twisting at the level of the cervix. Yeah, these were things we wouldn't be looking at actually. Yeah. This part of the world, I'm sure we'll be seeing more than the rest of the world, because we have so many deliveries. And
because here the average family size is 6, so you can imagine grand multiple is just a routine, but it was quite shocking. Yeah. That's why even Monica had to take time off. I think someone wants to.
No, that's how to claim CME. All right, any more questions? You can put the icon raise so that I can just open the house for any questions.
As a gynecologist, for us, we are all like, because I'm just practicing gynecology, it is for us, we are trained in MRI readings, but per se, we have never been trained to learn CT images. I think it's high time that we get into that as well, because it was so informative. And I have seen in emergency, any patient that comes with an acute abdomen, the first line of investigation is a CT rather than an MRI. And then because we rely so much on MRIs, maybe because it's good for the soft tissue readings, and but CT images needs to be read by us as well. Like, I think we need to be trained for that.
yeah, especially like, for example, in our center, MR time is like really tight, and we can't accommodate emergencies on MR. So most of the abdo related or gynecology related investigations go towards CT. But I do know of a few centers, especially in the US. I mean, I think they do have a lot of magnets. So I think was it UT of Texas? I can't remember. So they do a sizable even for query ectopic, they sometimes tend to do a very quick in and out MR. I don't think that's possible in most places,
Yeah.
but I think CT is the way to go especially when we just don't know what we're dealing with.
Absolutely, yes, because the first line of investigation is CT, always in emergency. And then if there is nothing from and nothing emergent, like nothing as an emergency, then over a period of time we usually land up doing her MRI. This is what I've noticed. And but today I realize CT has got immense role to play, and I think I have to learn to read the CT images, because for the CT I'm always relying on the radiologist report, but MRI at least we try to, get the more information discussed with our fellow radiologists and try to get more aware of reading the images. But CT is something which I think as a gynecologist we are less aware. I believe, Dr. Ritu, isn't it?
Absolutely. And,
Thank you so much, Dr. Jyoti.
My absolute pleasure. Thank you so much.
Thank you so much, everyone, for joining.
अच्छा जाओ ना बाथरूम से होके जाओ जल्दी आओ
Yeah.
पैम्पर क्लेम
Okay. Especially Dr. Amol, Dr. Yasir, and my sweetheart Trixia for arranging and organizing all of these. Trixia is our secretary. And thank you so much once again, everyone, for joining us. Thank you.
Thank you so much. Take care.
Thank
Bye.
you, Dr. Jyoti. Bye-bye.
Thank you so much, Dr. Ritu, Dr. Monica, Dr. Diana.
Bye.
Thanks. Thank you. Bye.
Bye.